Good morning. Thanks everybody for joining us. We're looking forward to a very provocative day. We have two sessions plus our breakouts to cover today. Our first session, which will start now, involves a update on IELCART activity, which is the Early Diagnosis and Treatment Research Foundation. And this is the initiative for early lung cancer research on treatment. So I'll turn it over. David Yankelevitz, I believe, is on the line. And David, if you could help us, thank you very much.
Well, hi, Jim. This session actually is going to start with Professor Flores, who's going to introduce the IELCART. He's the principal investigator with Claudia.
Well, thank you. I want to welcome everybody today. And we've got an all-star cast lined up. And basically, following in Claudia's mold, we are trying to set a paradigm shift for how we study medicine today. From a surgical perspective, you know, there's been several randomized controlled studies in surgery to try and answer surgical questions, where you had the Ginsburg study back in the 80s and Z30, you know, which compared lobectomy to wedge resection or sublobar resection. Then you had Z30 looking at nodal dissection versus nodal sampling. Nasser's study, again, looking at wedge or segment versus lobe. And many of those randomized controlled trials have not really changed the behavior of surgeons. When we want to do a lobe, we do a lobe. When we want to do a sublobar resection, we do a sublobar resection. And so all these resources get poured into these studies when it really doesn't affect our behavior. Very different from randomized controlled trials in medicine, looking at chemotherapy, looking at screening, et cetera. And so we figured, let's try to do a different theory in how we approach studies. So back in the 90s, Claudia and her group figured out through IELCAP that screening made a big difference. And we had to wait 10, 15 years later for the NLST trial to come out to actually believe it. So we figured if we use her methodology in surgery, because basically the way you cure cancer or lung cancer is by finding it early and taking it out, that if we could figure out what she did back then with IELCAP, we could take that same methodology and apply it to surgery. And the beauty of it is that it's simple. It's not so complicated. It's not fancy statistics, et cetera. It's a very simple way of gathering data and then analyzing it. And given the history of IELCAP predicting the utility of screening, we're going to try and use this same methodology to predict the utility of whether it's a lesser resection, whether it's a segment, whether it's a wedge, without the big, expensive, time-consuming, behavior non-changing randomized controlled surgical trials that have been performed in the past. So enough from me. Let's hear it from Claudia about where we're going with IELCART. And I'm extremely proud of the progress we have made over the past several years. Claudia?
Well, thank you very much. I appreciate the opportunity to talk about IELCART, and I thank the Prevent Cancer. And Raja, you just kind of summarized it. I can add a little detail and color to the discussion. But the first slide illustrates what you said. Think about it, in 1883 was the first pulmonary resection in Gdansk. And then pneumonectomy became the standard of care until 1962, when it was not resolved by a randomized trial, but rather by a retrospective review of 2 clinics. And then lobectomy became the standard of care and has persisted for the last 60 years. Amazing. Radiation therapy, on the other hand, started much later in the late 1990s It was used in Japan to treat early lung cancer, and then in the US a little bit later. There were multiple matched analyses that were done, but they didn't really answer the questions. And there were randomized trials that were done, but they failed to recruit enough people. And the pooled analysis of the two failed trials really showed that SBRT was better tolerated and had better overall survival, but it was underpowered. And so now the VALOR trial is underway, and we hope that will help elucidate the information. At Mount Sinai, Raja Flores and we all came around 2010, 2011, and you can see how the rate in the green line, how the rate of stage 1 disease increased. And so we need to recognize that we're going to have much more early stage disease. And for this reason, we started IELCART. Because after all, you can screen and diagnose all you want, but the treatment is what cures the patient. So optimal treatment is very important. And the Institute of Medicine in 2007 called for the development of treatment assessment based on information obtained in the context of clinical care. And that's what we try to address in our ELCART cohort study, where we make sure we capture all relevant patients. We use the usual care treatment as offered by the treating physicians, and we carefully document the long-term and the short-term and long-term follow-up results. We have a detailed intake process. We have a detailed follow-up process that we use, and we have a multidisciplinary group of PIs that are working on this. Dr. Taioli initially looked at a meta-analysis comparing lobectomy with sublobar resection, and the results were inconclusive of that study. We looked at quality of life, but there was very sparse information on that. And so Dr. Schwartz and Yip have worked on developing appropriate quality of life instruments. And we recognize the importance of surgical margin, and Dr. Wolf and Dr. Pass worked on incorporating that into the protocol. We have multiple participating sites. We love working with all of them and thank them all for their participation. They span a lot of places in New York City, in the Hudson Valley, but we also have international sites in Gdansk in Poland and in Rotterdam in Erasmus, in the Netherlands. So we really welcome other sites to participate as well in the future. Our surgeons at Mount Sinai are shown here, and we appreciate working with all of them. Radiotherapy is headed by Dr. Ken Rosenzweig, and we think that radiotherapy is an very important component that should be assessed. Our participating IELCART PIs are shown here. But all of that would not be possible without our Mount Sinai IELCART team, which works very hard. We have our coordinators embedded in the clinics working together on a regular daily basis. So that's a key part, and we work with all of the disciplines that they all provide and their talents. I'll send you after next week, I'll send you our first monograph. We wanted to look at the formation and background of ELCART and document it as it's going along. We wish we'd done that for ELCAP, but it's easier to start at the beginning. And so the table of contents is shown here. And then we'll have one article that gives a historical perspective. In this case, it's a historical review of thoracic surgery written by Fred Granis, which is very interesting. So I'll be sending this as a PDF, but then we'll also have a publication, and we'll work on other ones in the future. And as Raja said, we use a lot of the information we learned from ELCAP, predominantly the management system, which is key to making any of these collaborative studies work. And so we've modified the ELCAP management system for the IELCART management system. We have many topics that we address, and we really look forward to working on all of them. I'll just talk about a few of them. So surgical decision-making, we wanted to explore the factors associated with choosing lobar versus lobectomy, and to understand whether we can formulate a probability function. We looked at the frequency of limited resection, that's in the light blue compared to the orange colored. So you see tremendous intersurgical variability in whether they chose lobectomy versus sublobar resection. We looked at the factors and asked them to list the most important factor, and we see a lot of discrepancy. One chose nodule size, another one bronchoscopy, another one distance from the mediastinal pleura or age. So there are many factors that go into that decision that can be captured in a probability function. And we showed them multiple cases and recorded their decision and showed that we could really develop a probability function for each person, each surgeon. We have patient surveys before treatment and after treatment and at each follow-up. And we ask, I just show you one question, did you get a second option about your treatment? And surprisingly, predominantly in New York, these people said only 33% got a second opinion. Most of them did not. We said, where did you get your information from? Well, from the internet, but no other sources for 37%. Surprisingly, so there's a lot of information we're capturing and we'll be publishing on this. We asked the patients post-treatment, did the pre-treatment discussion prepare you for how you feel after treatment? Well, look, very well. We did 86% said very well, but there were 11% and 3% that said not so well and moderately well. And the reasons they said were there was lack of description of the post-operative pain, the recovery time, the quality of life, and other questions. So that gives insight into what we can do better. If we look at the patient and surgeon perspective, we see that they match fairly well on you see the patient perspective and the surgical perspective. But of course, the surgeons felt that they had prepared everybody moderately or very well. But the patients, 3% felt a little differently. We ask about post-surgical support group and recommendations. So did your physician present you any options to assist you in that post-operative period? And surprisingly, 59% said no. Did your physician have you meet a nurse navigator or social worker? 54% said no. But did you believe that your physician answered most of your post-operative treatment questions? 98% said yes. It gives you some insights on what we can develop, and I'll show you that in a moment. So the physician survey, we also have before treatment and after treatment, and we ask what are the most important factors. A lot of these questions are also so that they can be used in outcome analysis for looking at covariates. We also compared the initial choice that the surgeon made together with the patient with the final surgical procedure performed. And you see there's a lot of concordance. A little bit more sublobar resections were performed than predicted. Pneumonectomies were only 1%. So all of these comparisons are helpful for further analysis. We looked at quality of life. And Dr. Schwartz looked at quality of life from the SEER database from 1998 to 2014. And you see that surgery and SBRT surgery was always superior in terms of the physical component score, the PCS, and also for the mental component score. But there was a significant decline from the baseline, which is on the left, and to the follow-up time on the right. For both surgery and radiotherapy. The mental health score declined over follow-up for surgery only, not for radiotherapy. And there was no significant change over time between the two treatment options in that study. So we now looked at quality of life in our study at multiple time points. And so you see that lobectomy, shown by the red dots, they were both lobectomy and sublobar resection were equivalent at the beginning in terms of the physical component score, but lobectomy went down, but at the end of 1 year, they were both again at the same point. And for the mental component score, they were close together at the beginning, and lobectomy always stayed higher, and they came close together again at the end. So those are interesting information that we'll build on in terms of developing our program. And one of those is the mind-body intervention that Dr. Schwartz is suggesting for early stage lung cancer patients. It's to provide stress management and resilience training, or the SMART. And she'll be doing this in a pilot study of 8 weeks to see the feasibility before doing a randomized trial. And so her pilot study is funded. But all of that grows out of the information we've captured so far from IELCART. We looked at staging, and we strongly find that for early lung cancer, you really have to separate staging for solid and subsolid cancers. So here, for example, we looked at, and this is based on ELCAP data, because we don't have enough long-term follow-up as yet in the ELCART data, but we looked at angiolymphatic invasion and pleural invasion, and when you have both of them, then you see a decline in the long-term survival rates. But when you add the clinical information, the CT information to the pathologic information, then the invasion was no longer a significant prognostic indicator, which is interesting, and this is published. In subsolid cancers, far fewer of them, only 4.9% of them, have angiolymphatic or visceral pleural invasion compared to ones in solid nodules. And as expected, the survival was very good in those with subsolid cancers. There was only one death in a part solid nodule that had a big solid component. So we really think the staging for early lung cancer has to be separated for subsolid and solid cancers. The bottom line is that the nodule consistency on CT was a more significant prognostic indicator than either angiolymphatic or visceral pleural invasion. We also looked at assessment of mediastinal lymph node metastases using CT and PET. And here you see that PET scan is just above the 50-50. So PET is not really a significant predictor of mediastinal lymph node mets. It's very good for this cancer itself, but not for mediastinal lymph node mets. And the short axis of CT is better, but still not very good. So that's why I think we use, EBUS is becoming more and more used in pre-surgical assessment. Treatment assessments, we've published a lot based on ELCAP, but we're following that up with in IELCART. So we have the publication showing that lobar and sublobar resection have the same survival rates, long-term survival rates. We've looked at radiation compared to surgery back in 2014, and with only 10 patients, and then we've updated it with 24 patients, and they're very close together. We have all sorts of exciting imaging that we can do. We can look at lung volumes, and here you see before surgery, then after surgery, and then sometime much later, and to see what happens to the lung and to the whole shifting of the mediastinum. We found, for instance, that hiatal hernias were significantly higher, had a significantly higher incidence in surgical patients than non-surgical patients. And they were more frequent with lower lobe resection, which we would expect, more frequently right-sided, but they do have long-term complications of bronchiectasis and other things that we really need to consider. We're doing a lot with risk assessment, looking at integrating clinical, genetic, and imaging models to really personalize lung cancer risk prediction, recurrence, which is an important topic in IELCART, and then long-term survival. And these are all works in progress. We're going to integrate AI, of course, like everybody else. But remember, from the Tipping Point book by Gladwell, he said that it takes 10,000 hours to become a world expert. And so we think that AI will have to have a lot of baby steps, at least 10,000 baby steps, before they become a full-fledged partner in this whole process. So there's a lot of work still to be done. in that we have collaborative AI investigations with Tony Reeves, Mary Ellen Geiger, and Sam Armato, and Georgia Tarasi, and her co-workers at Oak Ridge National Laboratory. And we're going to be preparing the second monograph, which would be from 2017 to 2020. And we welcome any suggestions for the table of contents, and also what would be an important historical summary for that monograph. And in the end, we really need to treat the whole patient, as shown very nicely by this picture, and we need to personalize future lung cancer care. Thank you very much.
Master is up.
Yeah, so good morning, everyone, and good afternoon for those of you in the different time zone. I want to also thank Prevent Cancer for asking me to moderate this session. There will be two parts of this session. The first is a presentation made by our honorary thoracic surgeon, Dr. David Yankelevitz. And the second session will address an important question that I think is of concern to all of us, is how do we detect individuals who have early stage lung cancer that have a particularly more virulent biological behavior and therefore need to be treated in a different way. Before I get to this, I want to just present David. David is a professor of radiology at Mount Sinai, and his area of interest really is assessing the role of surgery in screen detecting lung cancers, particularly in the aftermath of the U.S. Preventative Task Force statements about the lack of validity of surgical treatment for these lesions. So without delaying anymore, here's David.
Thank you very much for the introduction. And so I'll be talking about evaluating the effectiveness of surgical resection, which is, hold on, we're just, page up. Yeah, these are my disclosures. So the draft guidelines for lung cancer screening have been released by the U.S. Preventive Services. And as part of those draft guidelines, there was an evidence review, which was prepared by the Agency for Healthcare Research and Quality. This is 2020, so it really just came out, and it was open for comments. And they'll then have a final version of this shortly. One of the questions that they asked and reviewed was how effective is surgical resection for SBRT and for surgery and SBRT for treatment of early stage lung cancer. And this is their answer. The strength of evidence for the effectiveness of surgical resection and SBRT for treatment of stage 1 lung cancer is moderate and low for benefit, respectively, downgrading primarily because the evidence came from uncontrolled cohort studies and imprecision. No RCTs comparing surgical resection or SBRT with no treatment for stage 1 were identified. To me, this is a breathtaking statement. You know, you just have to think of the whole field of thoracic surgery. You have to think about lung cancer as the #1 cancer killer. And what we're saying is there's, you know, moderate to low benefit for the primary forms of treatment. What does that do to, you know, trust in what we're doing? So the question that should arise then is, why not randomize? Why aren't we doing randomized trials for this if it's such an important illness? Well, the first answer to this is there equipoise? Is there an absence of evidence that you know, that we don't know whether or not the experimental intervention is really better or not? Can we do a randomized trial? Now, this type of principle of equipoise only applies if there's really not a substantial degree of certainty regarding whether the treatment of early stage lung cancer is useful or not. I mean, randomized trials weren't designed to compare things with obvious answers. They were designed when there was, really equipoise. That's the basis for it. So is there really equipoise in the idea that surgical treatment for stage 1 is not beneficial? Well, just as a start, I think the evidence just from registries is remarkably strong, that untreated stage 1 is highly fatal. And if you look at the current staging system, you see that treatment of stage 1 or early stage cancer is highly dependent on size and is highly effective. And I just show these two examples here. This is from untreated stage 1 on the left. This is from the California registry. And you see that untreated stage 1, this is all stages. But you can see for stage 1, does very poorly. 80% or over 80% are dead within 2 years. And on the right, you see from the ISLC, stage 1 on the top, over time, this goes out to, I think, 10 years, and it's like a 90% for stage 1 overall cure rate. So these curves to me are by themselves, highly, highly informative regarding the benefit. I just lost my, Now, even more directly looking at this situation, just look at the natural history of stage 1. This is, a very simplified version, but, as we think about tumors and tumor volume doubling times, by the time a cell has undergone 30 doubling times, it's 1 centimeter in diameter, and by the time it's 40 doubling times, it's 10 centimeters in diameter, and the patient is dead. So let's just take a concrete example. Think of a 1 centimeter tumor with a doubling time of about 60 days. Maybe this is a little on the fast side, but fairly typical within the screening context for cancers that are found on repeat screening. So a 2-month doubling time, left untreated at 1 year, this would have undergone 6 doubling times. It'd now be 4 centimeters in diameter. And by 2 years, patient would be dead. It would be more than 10 centimeters. So again, this is just highly, highly informative regarding lung cancer being highly fatal and surgery being highly useful. And it just always brings to mind this famous example that was published back in 2003 about the idea of whether or not you need to randomize the intervention of parachutes for parachute jumping as to whether or not they're of any benefit. And the only reason I bring this up is that the authors of this article concluded that sometimes all that's necessary in regard to demonstrating benefit is common sense. And then they go on to invite those strict EBM advocates to participate in a double-blinded control study of parachute versus no parachute. But more to the point, let's just look at this issue of whether or not there was or was not a randomized trial for surgery. So this is the rationale. This comes from the NLST protocol itself. And they said the major impetus to migrate from chest X-ray screening to CT for lung cancer is the promise of detecting smaller cancers. Yet we do not know that the outcomes are necessarily better when the cancer is 2 millimeters as opposed to 20 millimeters. As purveyors of public policy, we're obliged to avoid premature endorsement of a screening process before its benefits and liabilities have been reconciled. This is directly from the NLST protocol. What they're saying is we don't know whether it's better to treat a 2 millimeter cancer, which at that time people thought was the type of cancer you'd find with CT, versus a 20 millimeter, which is the type you'd find with chest X-ray. So if you wanted to answer this question in the most direct way possible, say whether it's better to find it when it's 2 millimeters or wait until it gets to be 20 millimeters, how would you want to study that? The most direct way possible, and answer the question directly. You would do this. You would take lung cancers that were diagnosed, you'd look at the lung cancers, and you'd randomize them to immediate treatment when they're small versus delayed treatment when they get bigger. And then you'd count up the number of deaths. And that is how you would answer that question. It would be the simplest, most direct way to do it. However, you wouldn't get anybody to participate. You would get no doctors, no ethics board to do it. It's not possible to do this trial. But this is the trial that you would do to answer the fundamental question that the NLST sought to answer. This is the way to do it. And if you really wanted to answer the question about chest x-ray versus screening, which one finds them earlier and how much better and how much earlier, you would take everybody, a group of people, and you would screen both of them with the same test. You do a CT and a chest x-ray on both of them, and you compare the size and stage distribution of the cancers you found. And that would answer the question about the difference between CT and chest x-ray. This you could do, and it would be very quick. You could get the answer to this portion of the study in 2 years' time. You'd know what happens on a baseline round, you know what happens on an annual round. So ultimately, you could answer all of the questions that NLST sought to answer with this type of study design. Screen everybody, then see what the distribution of cancers were, and randomize to early versus delayed treatment. This would give you all of the information you need and even more than would be provided by the NLST type design or the Nelson type design. However, you can't do this. Not possible to do this. So how do we get around this? How do we do it? Well, we randomize to CT screening versus chest x-ray screening. In other words, we don't randomize at the treatment side, we randomize upstream. We randomize to the diagnostic test. And we randomize so that in one arm you get early diagnosis plus early intervention. And in the second arm, the treatment arm, you get late diagnosis and late intervention. Now this avoids that ethical dilemma because you're not denying treatment to any particular person in that screening arm, in the control arm, because you don't know which person has the early cancer that you're not treating. So ethically, there's no problem here. The early cancers that are diagnosed in the CT arm, you treat them immediately. You know there are early cancers in that control arm, but you just haven't seen them yet. You don't know who has them, so there's no ethical dilemma. And then you count up deaths. Problem is that there's some inefficiency in this design. It takes a lot longer to do. You don't get all of the details in the control arm. You just get the overall comparison. So comparing those two designs, the first approach is much more efficient in terms of number of participants. It provides additional information about curability, but the second approach, the traditional approach, avoids the ethical dilemma. The point, though, that I'm really trying to make here is that ultimately, both of them provide that critical endpoint regarding reduction in deaths. In essence, both of these are randomized trials comparing surgery for early disease versus late disease. You just get there a little differently, but they're both randomized trials of the treatment. That's ultimately what prevents the deaths. So when they say there's been no randomized trial of surgery for early versus late disease, that's not correct. I think it is correct. We've done this, and we've done it in two remarkably successful trials, the NLST and the Nelson. Both of them show that early treatment of early disease is better than treatment of late disease. Now, here's where it gets interesting. Based on the results of the NLST and Nelson, the U.S. Preventive Services now rates the evidence for the benefit of screening as high. At the same time, it rates the benefit for surgical treatment and radiation therapy as moderate and low. So the benefit from screening ultimately comes from early treatment. That only comes as a result of the early diagnosis. Therefore, it really should be acknowledged. You can't have it both ways. You can't say that the evidence for screening is high, but the evidence for surgical treatment is only moderate. It really must be high. And the reason I think this is so important is that while the evidence continues to accumulate regarding benefits of screening, its uptake still remains low. Reports that undermine the evidence base for the primary form of treatment only raise additional concerns and cast doubt upon the entire screening process. As the surgeons know, and I like to remind them because they're kind of a shy group and need encouragement, surgical treatment of stage 1 lung cancer is enormously effective. And it should be understood that the evidentiary basis for this should be considered high. And we all need to understand that. This is a fantastically effective treatment, and it should be recognized as having a very strong evidentiary basis. That's it. Thank you.
Thank you, David. So maybe just one question for you so we can move on. You know, unfortunately, these recommendations are out now in the public space. And my understanding is that they're past the comment phase also. So how would you suggest that that the counter argument be made effectively?
Well, I certainly put in comments on this. I mean, I wrote my commentary to the U.S. Preventive Services. I don't know, I don't think they've responded. I think there's still a couple of months left before they make their final, but I am seriously doubtful that they will change this. This is very hard to convince that, you know, it's very hard to get them to change when they'll say there's been no direct RCT. So this is the point. I am going to try to publish this, and I think others need to you know, carry this message out there. That's really all I can think of doing.
Seems like if you send a letter to a New England Journal or something, you need to get something out fairly quickly, I think.
Well,
Maybe
we'll try. Maybe we'll. I mean, we have the article written, and I have the leadership of IELCART is on it, and maybe we'll get some more people to sign on to it. But I think it's important. I really think this is a serious misunderstanding. This is not a minor group that's saying it. This is a major organization that's saying, and it's not the first time. In the past, the PDQ, the Physician Data Query, which is sponsored by NCI, has been saying this for years in their guidelines regarding lung cancer and lung cancer screening, that the evidence basis for surgery is not good or is only moderate. So I think that's important.
Now, this topic has been a crucial topic in the last years before we opened up the outcome, the mortality outcome of the Nelson. Since the only thing that could spoil the end result was what we would call the treatment delay. So if you do the early diagnostics and you don't have an adequate in terms of treatment, then the early detection doesn't make any sense. And I think that that is a real plea also for, and an underlining of what David said, that if you do this really mass exercise to have all those patients in the early stage, and then you have pulmonologists also in our study that just wait because they didn't trust the outcome, or said let's just wait another year. So the whole impact is then gone. So I think the next step is indeed what David says, that we should emphasize that the treatment is related to the early detection. So there's no way that you can be successful with early detection without early treatment. And
I think this is an important discussion to have, and I think we're already behind schedule, and I can see how this can consume the rest of the day. So why can't we just let's move to the next phase? And do you guys see the slides?
Yes.
I was so apprehensive about sharing my screen here. So the next is a panel discussion, and my interpretation of the objective of this is understanding how we can risk stratify patients who have resected early stage non-small cell lung cancer, screen detected or not, in a way that would better inform how we treat those patients and how we surveil them. And to that end, we have assembled a spectacular panel. I will introduce them, not that they need any introduction. So Dr. Ignatios Witsuba is the division head of pathology and laboratory medicine at MD Anderson. He's also the chair of the Department of Translational and Molecular Pathology. Dr. Chris Amos is the director of the Institute of Clinical and Translational Research at Baylor College of Medicine. Dr. Matthias Woodkirk, he's a professor of radiology at the University of Groningen, and he's also the PI of the Nelson trial. And also my friend Harvey Pass, who's the Steve Banner Professor of Thoracic Oncology at NYU Langone and the chief of the Division of Thoracic Surgery there. I thank them all for participating in this panel. And just sort of to frame the question, this panel and this audience may not need that information here, but we know that even at early stage lung cancer, not everybody achieves that spectacular 92% 5-year survival. More likely it's closer to 70%, and in stage 1B even less than that. And unfortunately, these constitute a minority of the overall lung cancer population, and the hope and promise of screening is that that stage shift would occur. But in the meantime, we need to figure out a way to determine which of these stage 1s and 2s and 3s are deserving of more intensive therapy. And as you all know, there is really nothing at this point in time. There's a lot of work in that space, including the recently published ADORA trial on but for the majority of lung cancer patients, at least in North America and Western Europe, chemotherapy remains the standard care for adjuvant therapy. And this is familiar to all who practice in the lung cancer space. The meta-analysis by Pignot that summarized the data from all published randomized trials in the mid-2000s that show that the benefit is statistically significant, but it's really it's hard to argue that it's clinically meaningful overall, although if you classify it by substage, it may be more beneficial in patients with stage 2s and 3s than stage 1s. But that's what we have to offer these patients in 2020. Now, there are for sure trials that are ongoing, and hopefully we'll get some breakthroughs, but that's what's on the table now. And this is taken from a paper by Mark Chris, and it really brings the point home for the purpose of this panel. You know, this is a summary of all the trials, and it's a bit complicated, but the pale gray color are those patients who will die, whether they receive chemotherapy or not. And then the dark charcoal gray are those who will live, whether or not, without receiving any chemotherapy. And the yellow color are those patients who actually benefit from chemotherapy. So as you can see in stage 1 disease, that number is in the single digits. It's a little better for stage 2 and 3. But the point here is that a lot of patients may end up getting therapy that they will not need, and that is associated with perhaps a lot of adverse events and the quality of life issues. So with that, I want to sort of direct the first question, and I would strongly urge the panel to interact if they have anything to say, but maybe start with Dr. Witsuba. And the question I have for you, Dr. Witsuba, is as a surgeon, I have been hearing forever that there are pathological markers of poor outcome, LVI, poor differentiation. Of course, the big one is nodal disease. So where do you think we are in terms of having some panel of pathological or even molecular genetic markers that can be generated in the translational lab in pathology that would guide us in making more informed decision? Is that something that we can still look forward to? Your thoughts?
So can you hear me, right?
Yes.
Good. So I think that, you know, in the field of lung cancer across the board, including early disease, I think that the field has been working on predictive markers that tell us who to treat and what to use in the treatment. So the prognostic marker actually are not, in my opinion, the backbone of the interest in biomarker, despite, you know, multiple publication on predictive, on retrospective cohort of cases. While it's interesting because some of these markers may tell us about the biology and maybe classification of certain tumors, I don't think there is a marker that now we can call prognostic, except probably the imaging for after the lesions. in my opinion. And I've been actually being involved in early studies of gene signature panels and protein expression marker panels, and they can tell you actually good information about the prognosis, but none of them have been taken to a prospective clinical trial, or few of them are taken to a prospective clinical trial and answer questions about adjuvant therapy, for example. What you actually need to do is not just say, okay, your prognostics worse than others or better than others. So I hope I'm not showing my bias here about my not strong interest in prognostic markers and more interest in predictive. So the other challenge with some of these small lesions is to have enough material to do good analysis, right? So, and I really think that if we really want to learn more about the biology of this tumor and even come up with some prognostics tool, is to have samples prospectively collected and run them through novel technology that allow us to get a large number of information. I'm talking about genomic analysis, on immune profiling analysis these days. I believe that maybe there is potentially more information in the immune response and how we can actually manipulate the immune response to these lesions than the genomic. How we can, because there is very limited, if it's a driver, you can do something, not the driver, there's not much that we can do. So maybe in the immune space with immune checkpoints or other intervention, maybe I could actually have a good ways to intervene on the fate of the lesion and then have predictive biomarkers. That's it. So that's kind of my general approach to this.
Thank you. So Harvey, do you think clinicians are actually over-treating patients based on a pathology report that you get that says, this patient has a poorly differentiated tumor with LBI and measures maybe 3 centimeters or something?
So I don't think that there's, well, the question is, are we operating on patients that are not going to kill? Is that your question? Or do you think that we're not using enough data to figure out who to operate on?
Well, I think the question really is, are we trying, do we have enough information to pick out those patients that need more intensification of therapy or intensification of surveillance versus those that do not and are sufficiently served by an operation?
I think that we don't. And that's part of the reason why there are interests between places like NYU and MD Anderson looking at grants of pre-malignant lesions and trying to look at the clonal evolution of those lesions and figuring out which ones are going to be bad or not. We really have not been able to, even with the ones that are not overdiagnosis, make a good decision about who's going to recur and who is not going to recur. And that was one of the questions that was posed to me, whether the immune situation, which Ignacio talked about, would help us in this prognosis. Do you want me to address that at this point?
You're muted, Doctor.
I'm sorry, you're muted.
I'm sorry. Yeah, maybe you could hold off on that.
Okay.
For now, and what I would like to hear more about really is what's all the buzz about, Chris, on circulating tumor DNA and liquid biopsies. Every patient that comes into my office, can I have a liquid biopsy, please? And so on. So where do we stand in terms of these circulating biomarkers, but more specifically circulating tumor DNA in early stage disease?
Well, so, I'm going to join the rest of the panel in expressing some reservation about that for the early.
Well, you guys cannot all have reservations. Somebody has to say something.
Well, so the issue till now has been that the size of the tumors that are the ones that we want to characterize for early stage prognostication is small enough that they're not releasing enough tumor to provide a sensitive assay for circulating tumor DNA, as far as I know the literature. So the problem is a detection one. We have to be able to
I agree with Chris. Hi, Chris. So I think that also we have done some studies in which we have run, several groups, whole exome sequencing of these early lesions from premalignancy to small invasive tumors, and there is a progression of subclonal evolution of abnormalities. So many of them they may have a driver and they don't have too many other abnormalities. So the amount of changes is not so high. So maybe even you have a very high sensitive cell-free DNA assay, but you may miss abnormality because the tumor is not shedding enough to be available. So I believe on cell-free DNA very much as a minimal residual disease approach. After you resect an early tumor, it's a great way to potentially follow up this patient. We have experience in colorectal cancer here and other tumor types, but for unresected lesions, small lesions, is hard. It's hard to for me to believe that it's going to be very useful.
So we can certainly argue whether or not even in minimally residual disease, circulating tumor DNA is really a useful, it's useful when you find it. Many times you don't find it.
Yeah. I agree, but one thing is there is a new concept now that is tumor educated. I think that's tumor educated cell-free DNA. Basically, the concept is you resect the tumor, you do whole exome sequencing, you know what the tumor has, right?
Yeah.
You don't go by chance. 53
Yeah.
usually we all pick on that because it's 60% or 80, but there are 20% is not. So you educate your panel, then you do a hybrid capture in your cell-free DNA, and then you pick the ones that the tumor had, and you check those. Maybe that's a
personalized approach.
Yeah, personalized, yes.
And that's not that hard to do because, usually there's a KRAS mutation or EGFR or something, so it should be fairly feasible.
So Professor Utker, surgeons understand imaging better than other things like circulating tumor DNA, methylation markers. So, and we understand, for example, that if you have a tumor that is hot, then it's likely to be bad. Tell me a little bit about your thoughts on how we can use various types of imaging to predict biological behavior, whether it's PET or CT, or perhaps even you can comment on the emerging role of AI in trying to predict biological behavior. And
you're muted.
You're muted. Yeah, excellent.
Yeah, okay. Thank you for those questions. There are many questions in a small sentence. Now, first, I think what other imaging modalities can do. Now, the problem, of course, is for tissue characterization. MR is mostly the most indicated methodology that it will give you the best specificity in the liver, in the brain, in the bone even, But in the lung, since it is surrounded by air, which is not cannot be visualized with MR, and the nodules has to be caught in a stage that the spatial resolution is a real problem in MR. For tissue characterization of nodules, MR does not suffice. There's more and more evidence that MR could play a role in metastatic disease, but that is not that's a little bit in contrast with the thing that we want to reach with early detection. On the other hand, PET has a comparable problem. The earlier the stage is, the more false negative PET outcomes you will have. Now, with the common PET installations worldwide, you would not really be able to get a spatial resolution better than a typical cubic centimeter. And that is already very large for the detection thresholds that we have in with CT. CT at the moment goes down to 30 cubic millimeters for new nodules as a threshold, and that is a spatial resolution that is far beyond anything PET can do. So at the moment, even with the latest techniques, which gives you more spatial resolution also for PET, I think you are really in the dark. Then there is the metabolism, of course, that is used with PET. It's mostly up till now with FDG, and that reflects more or less only the glucose metabolism, and that is probably not always the way that the tissue can be characterized. So it's a very, very general metabolic marker without very narrow specifications of all kinds of different histological tumor types. So with CT, what we find now and what we use more and more is that the volume doubling time will be probably the most crucial. So the growth rate, in fact, the growth rate will really tell you the most about the tumor. Also about the urgency, in my view. So in the examples that David showed, he showed two examples that, if you hear it, then you think that's quite common. But those examples were extremely high growth rates. So if you have growth rates with a doubling time beyond the 200 days, that is already, in our experience, very fast. So when we started the Nelson study, we thought that we were nervous about the fact that we introduced this indeterminate category that you don't have in the NLST. And we just wanted to have 2 time points, so one at baseline and second after 3 months, to establish this volume doubling time. And we then, with the ethical committees, and that's still something that is, for example, in China, very much under debate, that you can you wait 3 months? And now that reflects a little bit the idea of of early detection generally, but also the idea that the medical community thinks about growth rate. And we found, and I think I was also quite nervous in the beginning, if we could really do this. And we know, and by the Nelson study, we know that we have ample time. We won't, perhaps we just, no, I'm not aware of one miss of waiting 3 months for the second point. So you probably can even wait 6 months, even with a very high growth rates. The highest growth rate that we found was 47 days in one tumor, and we didn't miss it. So you could argue that the interval cancers are those very high growth rates, and in the interval cancers, we had a very low rate of interval cancers in the Nelson, and half of those were misses. So were missed in the first baseline scan. Now that brings me to the AI. the AI is in its technique oversensitive. So you will get enormous high rate of false positives. But false positives have another side that when you have a negative outcome with AI in the future, and I think that could bypass more or less 50% of the cases in a typical population like in the Netherlands or in Germany, that would drastically turn down the workload. And at the end, I think we could, with AI, go down to only reviewing as a radiologist something like 20%. But then again, we have only this baseline scan. And then the interaction with the radiologist will be absolutely mandatory. But when we have the baseline scan, AI is extremely capable without any intra or inter-observer variation to do the same trick again on a comparable data set and tell you what the differences are without any interference of the radiologist. So if you would install in the future, from my point of view, an early detection program, you have to have a lot of energy for the baseline, and you do your very best there. But then in the new rounds, I think AI will take it over for 99% in the future. So that means that for new nodules, and 55% of the new nodules will disappear in a year. So that's also an important thing to realize. We will not miss that many nodules. And on the one hand, and on the other hand, we probably can let AI do most of the work in the follow-up. So not at the baseline, but it will be probably very easy to do it in the follow-up with not that much work. And it brings me to the end of this answer. I think in the future, it will be probably the best, most effective, but a little bit discussion about radiation exposure. If you come up with one examination with two time points, when you in all cases do a baseline in 3 months without any interpretation, but only as one test at the end of the 3 months. And that can probably completely be handled by AI at the end. And then we have a very extreme, accurate way of determining the volume doubling time as the most important imaging biomarker and better than anything so far.
Thank you, Professor Onderdijk. So Harvey? So
yeah,
what do I do? Where are we going with all this? Is it do you see it's a tissue biomarker? Is it a methylation circulating biomarker? Is it a combination of things? I'm interested in what you have to say about the immunological profile. Put it all together for us.
I personally think that we don't have anything that is sensitive and specific enough at this point, period. And that's because we're just starting to see how complicated it is. And if you want to personalize it, it even becomes more complicated. If I can just briefly go through what my thoughts are in a historical perspective and share my screen, I'd like to give you an idea of, what I feel the deal is. Can I share this?
Yeah.
I wish I could, but apparently I can't.
We see it.
We can see it.
You see it? Okay.
Yeah. You can make it bigger. Yeah, there you go.
So,
Perfect.
So the bottom line is that the question to me was, can you do immune and all this sort of other stuff to figure out who's going to be good or not? And it's not going to be easy, because if you look historically at the leader in this, it really points out to you how difficult it is. And the leader, in my opinion, has been TracerX. I mean, TracerX started this in 2017, and we're talking about tumor heterogeneity. So when you biopsy many sites from even a stage 1 lung cancer, which they did, what they found was that they were all different. And they found that 30% of the mutations in the tumor were subclonal, and you had 48% of them having different copy number aberrations. Majority were seen in squamous cell as opposed to adeno. But the key issue here for screening, let's just say if you want to figure out who's going to be, the ones that are going to do bad or not, the ones that had copy number aberrations were the ones that actually did the worst in this group of patients. So that was the first hint that a genomic parameter may tell you in early stage lung cancer what's going on. Now, here's where all the stuff with early detection and DNA really started, in my opinion, not with Max Dean, not with anybody else, but with a wonderful trial in which they took the same patients and they did multiple blood draws on these patients. And then they took the multiple blood draws and looked not only at the clonal variations, but the subclonal, like Ignacio was talking about, in which you look at these downstream subclonal mutations that may be the bad ones, okay? And they made multiple assays for these and then looked in the blood to see if they could detect them. And squamous cell always wins. And it's always dependent upon the volume of the tumor compared to lung adenocarcinoma with the number of single nucleotide variants that you're going to find. So look at lung adenocarcinoma, you find not very many that have 2 in the blood, and that's what we still seem to have right now. But it will work. And you can see that if you get an increase in the blood of clonal variations, these patients will recur. And if you then use the personalized approach where you look at subclonal variations, even before you have the relapse here, you're picking up these subclonal variations by ctDNA. So it will work, but is it sensitive and specific enough? That's the problem. How do you increase your sensitivity and specificity? It gets more complicated because then you're talking about the immune system. And what do these subclonal variations do? They give you neoantigens. So the next interest with the Tracer X, which also has been really carried forth by Ignacio's group at MD Anderson, is the idea of measuring neoantigen proportion, neoantigen number, to see whether that actually has to do with how the patient's going to do. And it goes back to hot and cold tumors. If you look at lung adenocarcinoma, sure, you can look at all the immune markers and show that you've got tumor infiltrating lymphocytes, hot and cold, but that's not the end of the story. It's what happens within these various regions as to how the patient's going to do. And if you look in the various regions, you'll find that neoantigen production and how you're going to respond to it is dependent upon how many neoantigens there are, what they are, how they get processed, whether they get processed, whether you've got a mutation and how you're going to process them with the HLA. And you can have tumors that can have no evasion of the immune system. They're going to be treated. And tumors that are able to escape because they have mutations of HLA, because they immune edit the neoantigens or don't process the neoantigens. That's very well shown here. Finally, I mean, that's been validated in the MD Anderson group, the importance of neoantigen numbers, at least, with how these patients are going to do. Finally, everybody tries to get the easy way out. Here's the publication of the in silico immune signature that supposedly tells you how good these people are going to do from Stanford. Well, here's the discovery and here's the validation. Is this model going to be good enough to take to the clinic? Absolutely not. There are many more other factors that have to be added to this to make the C index greater than 0.64. And I think that you got to go back to the tissue, and then you're going to learn more. And I think we're doing that because now we have spatial GeoMX from nanostring that was actually started with all these manifestations of different cuts and overlaying and looking at different cell types that Ignacio does all the time with multifluorescence, immunofluorescence. But now you get spatial areas where you can look at regions of interest. And it turns out that if you have subclonal areas in multiple regions, those patients are going to do poorly. Me, I take a simple approach too. I look in the blood and I look to see what the immune system is doing in the blood, but I'm not good enough to do fluorescence. So I just look at immunotranscriptomics. And if you look at the blood of patients that recur and don't recur, you're going to find, using a 770 gene panel, great differences between stage ones. They're all stage ones, between the recurs and the non-recurs. And if you take these high profile genes, look at pathways, and you model, you actually can get modeling in which you can show differentiation between the recurs and the non-recurs, and that needs to be validated in a prospective thing. So there is a signal, but we really don't understand all the biology behind what that signal is happening in the Buffy code. And I think that's where we go in the future, but start with the tissue. That's my 2 cents.
Well, this was this is great, and great discussion. We are over our allotted time, and Dr. Mulshine must be chomping at the bit to get us off the screen. So I want to end this by thanking all 4 of you for an amazing panel discussion. I think that this is an area that is, as far as I can remember, ever since I started doing lung surgery, has been an area in which we were stuck and haven't made a move forward. But perhaps Harvey, with all those new developments in how we can multi-scale profile the tumors in both in the blood and in the tissue, we can actually start to break through that. Thank you all very much.
Thank you.
Thank you.
Thank you, Nasser. That was a spectacular session, and we appreciate the passion around these complex issues, and understand that time is, it's only one issue. But we're going to proceed, and we're proceeding to the targeted therapy for aggressive early stage disease, lung cancer discussion. And we have a talented panel, which I'll introduce after we get a framing presentation that Raj Velaswamy from Mount Sinai, who's a thoracic medical oncologist, has graciously agreed to put together for us. Raj, you want to jump in?
Sure, good morning. Just trying to see how I can share my screen.
Figure it out, tell me.
I don't have a...
No green button?
No green, oh, here. No.
We can do it here for you if you like.
Sure, and then I'll just say advanced slide. Okay.
Thank you.
All right, hi, as Jim said, my name is Raj Velaswamy. I'm a thoracic medical oncologist at Mount Sinai. So I just want to thank the organizers for inviting me to present here. This morning, I'll give a very brief overview of the recent clinical trials surrounding this early stage lung cancer space. Next slide. So as discussed, early stage resectable lung cancers currently make up approximately 25 to 30% of lung cancers at diagnosis. So this graph at the top left shows that the percentage of patients diagnosed at each stage is inversely proportional to survival. So it's clear that early stage cancers really represent our best chance for meaningful long-term survival and cure still. Additionally, this highlights the importance of lung cancer screening programs like IELCART and for widespread implementation of lung cancer screening. So now, despite complete resection of all clinically observed disease, as mentioned, surgical outcomes are less than optimal. Even for the smallest tumors, the 5-year survival outcomes are 90%, and survival goes significantly down the larger the tumor and with involvement of lymph nodes. The reason for this recurrence is thought to be secondary to occult micrometastatic disease or possibly some tumor seeding during surgery. It's important to understand the pattern of recurrence, and it's clear that the majority of is distant recurrence, providing rationale really for adding systemic treatment with surgery to improve outcomes. Next slide. The majority of prior studies is focused on the use of adjuvant chemotherapy. So there have been multiple phase 3 randomized controlled trials conducted in the 2000s, finding benefit for using cisplatin-based regimens for stage 2 and 3 cancers and a subgroup of 1B disease. The LACE meta-analysis combined individual patient data from 5 of the largest trials, pooled analysis of 4,584 patients with completely resected non-small cell lung cancer. Adjuvant chemo was associated with a decreased risk of death of 5.4% at 5 years. So that's a number needed to treat of a little less than 20. The survival benefit varied by stage, however, with most of the benefit coming from the stage 2 and 3 patients where you see statistical significance. There is a trend towards worse survival for the stage 1A patients, and stage 1B has always been a little controversial with a non-significant benefit in this group. Looking at the CALGB trial, which was unique because it randomized patients with stage 1B disease. Investigators stratified the cohort into by size, less than or greater than 4 centimeters, and they found that there was an improvement in disease-free survival in the subset analysis for patients that had greater than 4 centimeter tumors who received adjuvant chemotherapy with a hazard ratio of 0.66. And so we generally, as medical oncologists, really start having that discussion with Black patients, with larger 1B tumors greater than 4 centimeters. Next slide. The question of whether we should be giving systemic treatment prior to or after resection was addressed by a few phase 3 randomized controlled trials. This is the NATCH trial, which, like others, the CSLC trial, and really demonstrated no significant difference in survival outcomes between neoadjuvant and adjuvant approaches for chemotherapy. However, the observed difference across these studies was that significantly more patients completed induction chemotherapy, so in the 90 percentile, compared to the adjuvant groups, which were really more in the 60%. And so obviously, this difference can be attributed to potentially significant recovery period after surgery and so on. There are other advantages in the neoadjuvant approaches worth discussing. And so there can be earlier introduction of systemic treatment to prevent or treat existing micrometastatic disease. There could be potential for tumor downstaging, resulting in an easier or more complete surgical resection. And then, of course, in vivo assessment of treatment sensitivity, which really has important clinical trial implications, as we'll discuss. However, these advantages always need to be balanced with potential disadvantages, especially when considering designing future early phase trials. And so potential disadvantages might include treatment-related toxicities that could delay surgery, changes to the operating field because of treatment, which may complicate the surgery, disease progression through treatment, and of course, patient anxiety while waiting for the surgery. Next slide. So adjuvant or neoadjuvant treatment for aggressive early stage lung cancers remain largely unchanged until recently. And that's whenever we really start seeing that immunotherapies and targeted therapies are resulting in unprecedented survival outcomes in the advanced stage setting, and that these agents are generally well tolerated. And so on the left, you can see the long-term outcomes of the Keynote 010 trial, where they randomized patients receiving second-line treatment to pembrolizumab or chemotherapy, the single-agent chemotherapy. And so, you can see here on this Kaplan-Meier estimate that at 36 months, the overall survival rate for the pembrol-treated group was 35% for the high PD-L1 expressors. For molecular targeted therapies, EGFR tyrosine kinase inhibitors have really changed the whole treatment paradigm. The FLORA study in the EGFR mutated patients compared the third generation TKI osimertinib with first generation TKIs, and really showed very impressive long-term survival outcomes and great treatment tolerability. So there's been a lot of interest in moving these novel therapeutics forward in the early stage lung cancer setting. Next slide. So a few important early phase neoadjuvant immunotherapy studies have been published recently. These trials have really focused on the effectiveness of anti-PD-1 or PD-L1 blockade, and they used as endpoints things like pathologic response rate and objective response rate. So major pathologic response is generally defined as the resected tumor of less than or equal to 10% viable tumor cells in the resected tumor after neoadjuvant treatment. And so in this first pilot study reported in the New England Journal of Medicine, completed by the Hopkins and Memorial groups, there's patients, about 21 patients were given 2 preoperative doses of nivolumab. And they had stage 1 to 3 non-small cell lung cancers that were resected. The primary endpoint was safety and feasibility, and the authors concluded the side effect profile was acceptable with no delays in surgery. Importantly, major pathologic response occurred in 9 out of 20 resected tumors, so 45%. Responses occurred irrespective of PD-L1 expression. And but they did look, and there's some correlation with path response and pretreatment tumor mutation burden. The second study was a multi-institution phase 2 trial where stage 1B to 3A non-small cell lung cancer patients received atezolizumab, which is a PD-L1 inhibitor. And this was given with carbo and Abraxane for 2 cycles. And then imaging was done, and if there was no progression, they received 2 additional cycles, followed by surgical resection. The primary endpoint was major pathologic response, and of the 30 patients enrolled, majority actually had, 23 had stage 3A disease, and 87% of the cohort underwent successful R0 resection. 57%, so that's 17 out of 30 patients had a major pathologic response. Adding the chemotherapy did seem to cause some, more cytopenias, and then this cohort had a few patients had some LFT abnormalities, but generally it was thought that the adverse event profiles was manageable, and it didn't compromise the surgical resection. Next slide. This is the Nadim trial that was just reported. It's a single-arm phase 2 trial done in 18 hospitals in Spain. So patients with stage 3A resectable disease received neoadjuvant nivolumab with carbo and Taxol, followed by surgery, and then they're to receive 1 year of nivolumab adjuvantly by design. So in the intention to treat population, which consists of 46 patients that received the neoadjuvant treatment, of these 41 underwent surgery. So at 24 months, 35 of the 41 patients who had tumor resection were progression-free, and this was the primary endpoint. Longer follow-up, of course, is going to be needed. What might be most striking is the pathologic response with a major path response of 83% of patients. And 59% of patients actually had no viable tumor cells on resection, resected tissue. Next slide. There are several adjuvant immunotherapy trials in non-small cell lung cancer currently underway. The first ever done was a vaccine trial against MAGE-A3 antigen. However, this Margaret study and several other smaller studies really never showed a benefit, and the investigation of this approach has since been discontinued. There's several adjuvant checkpoint inhibitor trials currently underway. However, it's going to take some time before they'll be reported out. Next slide. Switching gears to the targeted approaches, the focus has really been on EGFR, which is the most common driver mutation with an FDA-approved targeted treatment. So there are 5 prospective clinical trials about evaluating EGFR TKIs as adjuvant treatment. In the SBR19 study, investigators evaluated gefitinib as an adjuvant therapy for unselected patients. And so they did not find an improved disease-free or overall survival. So again, researchers did not assess EGFR mutation status for patients before treatment. In the RADIANT study on the right, stage 1B to 3A non-small cell lung cancers were randomly assigned to erlotinib or placebo. Here, researchers evaluated EGFR status as protein expression by IHC or EGFR amplification by FISH. And again, they did not find a survival benefit. In some post-hoc analysis, they looked at only 16% of patients had EGFR mutation status confirmed. And here in that small subgroup, there seems to be a disease-free survival benefit. Next slide. The SELECT study was the first study testing the efficacy of adjuvant erlotinib in EGFR mutated non-small cell lung cancer patients with stage 1A to 3A disease after completion of standard adjuvant treatments. The 2-year DFS was 90% with the median DFS and OS not being reached. So here there's no comparison arm, but obviously these survival estimates are better than those seen in historical data. The CTONG study from China was the first phase 3 randomized controlled trial testing the efficacy of gefitinib versus cisplatin-based chemotherapy in patients with sensitizing EGFR mutations following resection of stage 2 to 3A non-small cell lung cancer. So results show significant longer disease-free survival, about 10 months longer with the tyrosine kinase inhibitor compared to chemo in the adjuvant setting. In addition, the TKI-treated patients experienced fewer adverse events. Next slide. At ASCO this year, the overall survival data was presented and demonstrated adjuvant TKI here did not provide an OS benefit. So this data asks the question, are we just kicking the can down the road and simply delaying recurrence? And so arguably that might be okay. I mean, there might be significant quality of life benefits and other benefits. And furthermore, this is still lung cancer where we typically give the best treatment up front. More recently, the best treatment in this space appears to have changed. Next slide. Here's the recently published ADORA trial. Here, EGFR mutated patients with stage 1B to 3A underwent complete resection, and then they may or may not have gotten chemotherapy, and then they were randomized to osimertinib, the 3rd generation tyrosine kinase inhibitor, or placebo. And here we see a really impressive disease-free survival with a hazard ratio of 0.21 for the entire cohort, and it's even better for this stage 2 and 3 disease with a hazards of 0.17. The disease-free survival benefit was consistent across all subgroups they looked at. And one of the important outcomes to note is that there was a significant reduction in CNS recurrence in the OC-treated group. However, we don't have the OS data yet. And but for the most part, I think a lot of it's believed that this significant DFS benefit will carry over to an OS benefit. Next slide. So in conclusion, just a few discussion points or thoughts. Early stage resectable lung cancer still represents the best opportunity for long-term survival and cure. Neoadjuvant and adjuvant treatments improve surgical outcomes in selected patients. And we, especially when designing future trials, we should really balance the advantages and disadvantages of neoadjuvant approaches. And to this point, endpoints really need to be validated, such as major pathologic response and DFS. Chemotherapy certainly still has a role in the surgical management of high-risk non-small cell lung cancer, although it appears more now to be in synergy with these novel agents. And finally, as we've been discussing this morning, novel biomarkers are needed to predict disease recurrence post-surgery. Thank you.
Thank you, Raj, for an excellent and comprehensive overview of where we stand. Obviously, there's a lot of new and important findings in this space. And to help us sort through that, we have a very distinguished panel of Fred Hirsch, head of thoracic oncology at Mount Sinai, Phil Dennis, head of lung cancer strategy at AstraZeneca, Roy Herbst, deputy director of the Cancer Center at Yale and distinguished thoracic oncologist, Natasha Lahill, a chair at Princess Margaret in Toronto and also a distinguished thoracic oncologist, And I know we'll be a little tight for time, but I would like to share my screen. 1 second. Yeah, no. It's Adrian's document. The document's open. Yes. Okay. Thank you very much. Sorry for the delay. The first question, we have a series of questions we're going to go through with the panelists, and we'll start out with the success of the trials that we just heard from Raj. Is it time to reconsider the situation where the earliest stage disease, we saw from the meta-analysis that was discussed that there was adverse outcome, but that was with chemotherapy. What do we think about stage 1A disease, which is the bulk of screen detected cancer that we hear from other presentations this morning that is rising, for consideration now in terms of therapeutic index with this subset of stage 1A disease that behaves like the wolf in sheep's clothing. So Fred, you've been thinking about this a long time. Your thoughts on whether or not we're ready to start bringing back adjuvant therapy this earliest stage of lung cancer?
Yeah, can you hear me? First of all,
Perfectly.
thanks for the invitation to participate. I'm certainly very enthusiastic about focusing on early stage disease. With all the therapeutic advancements I've seen for advanced disease, it is certainly overdue time to move this into early stage disease setting. We have two options. We have adjuvant therapy and we have neoadjuvant therapy. There are advantages for both of them, although the clinical studies and results on this stage doesn't seem to give any clear difference in outcome as far as we have of data today. Whether stage 1 disease is different from others, I would actually think that I would consider early stage disease, stage 1, 2, 3A, in a kind of the same field. And ADORA study, which Roy have presented recently, clearly shows that targeted therapies has a role in adjuvant setting. I do believe we don't have data yet from a big NCI trial, but they will come one day too. What is the advantage of this? I believe that early stage disease has more antigens. There are a neoantigen load from dying cells, which all give a better priming for immunotherapy. So I think there is a role for immunotherapy. I think there is a role for targeted therapies. We need to get the studies done, and we need to have the data to show it. I think taking neoadjuvant approaches first. The data are promising, but as Raj very elegantly spoke about, we are still kind of struggling with harmonization of the endpoint major pathologic response, which is impressive in some studies, in others less impressive, but I think it is reflecting disharmony in the interpretation of the endpoint, and we need to have that cleared out. I know that ISLC are working with FDA to do this type of studies and assembling data from different studies. With the targeted therapies for early stage, I'm a strong believer, whether we are talking AA, 1A, B, or 2 and 3A, as mentioned. We need for neoadjuvant approaches to see what the Lung Cancer Mutation Consortium 4, edition 4, will give us of results. LCMC4 is studying different targets in a neoadjuvant setting. Of course, we don't have any results from that study yet, but we are, with the knowledge we have for heterogeneity and molecular characteristics of lung cancer, and with the advances we have seen in later stage disease, I am very convinced that we will see further improvement and significant improvement in early stage disease. That was a long answer to your question, Jim. I don't know if that answered your question concretely.
Very important comments, Fred. Thank you very much, and a lot to chew in on. And I'm going to kind of march through some questions for additional panelists, and if they want to come back to issues, please do so. Phil, Dennis, having participated in this workshop previously, you've been thinking about issues of therapeutic index and adjuvant therapy in this very, very early disease context, this 1A, not stage 2, 1A. As a member of pharmaceutical development team, what do you think about in terms of the characteristics of a drug to be applied in this setting, in terms of both efficacy and in terms of the safety index?
So thanks, Jim. Yeah, this has been a great presentation. I'm sorry I'm having some technical issues, but I do want to respond to the 1A question, and I agree with what Fred said. But I think that what I go back to is that we overtreat many patients with stage 2 and 3 disease with adjuvant chemotherapy now, and we really don't know the patients who benefit most. We have some sense of it, and I think that's the critical question for the 1A patients, right? That most of these patients will do well, but there's a significant proportion, certainly many more than stage 1A breast cancer patients, that will do poorly. And so the question is, how can you identify that? And what I can tell you from an AZ perspective, what we've done is, and the TRACERx data was cited earlier, we really have placed a lot of investment in the idea that circulating tumor DNA after surgery is the best way to prove that there's remnant tumor tissue that will ultimately recur without any intervention. And I think what applies to stage 2 and 3 in that setting, and again, we have a study now called Mermaid 1 that is testing whether or not MRD positive patients stage 2, 3 after surgery will benefit from more intensive therapy, either our checkpoint inhibitor durvalumab plus chemo versus chemo. So I would argue the same thing would be true for stage 1A patients, that you really need to identify the highest risk patients and go after them first. And then the question is, what do you use? Well, I think the ADAURA data is pretty impressive, and I think certainly if you had an EGFR mutation, probably would test Tagrisso in that setting. The question is, would IO be beneficial, and how do you view that benefit risk? And I think one of the challenges would be, you know, do you incorporate surrogate endpoints such as clearance of that ctDNA? Do you vary the treatment length, right? So in other words, do you really need to give a year or 2 years, an arbitrary time period? So I think those are the kinds of considerations that I know we're thinking about, because we do want to move into the 1A space as well, because I think if any patient with lung cancer had circulating tumor DNA and it was a bespoke panel, meaning the only source of that DNA and the only pattern of that DNA, the origin of it can only be the tumor that was resected, then that patient's going to recur without treatment. And I think that's the kind of approach we're taking.
Yes. Phil, thank you very much. Important comments. Roy, first, I want to stop before we jump into this and congratulate you and your colleagues on your tremendous effort in bringing forward the ADURA trial. I mean, that's a multi-continent collaboration, very complex study, very important study with very robust findings. So congratulations. And in light of the comments you've heard from Fred and from Phil, we have this issue of therapeutic safety in this very, very early 1A. We have potentially a couple of different approaches that have been discussed in the previous panel about how do you find the wolf in sheep's clothing. In light of your exposure now to this adjuvant setting in more advanced disease, what are your thoughts on the issues that we've kind of brought to the fore so far in this panel?
Right. Well, thanks, Jim, for your nice comments. Certainly, the ADORA was 1B to 3A. Of course, the DFS, data, as was shown, is really extraordinary. We await survival, but even as we wait that, we actually showed at ESMO and in the paper that sites of recurrence like the brain are so much affected. So what about 1A to move it earlier? I guess it's a risk benefit, as everything is. When you compare to placebo, even a drug like osimertinib, which is more targeted, third generation tyrosine kinase specific, is going to have more side effects, usually grade 1 and 2, thank goodness. But is it something we should use? I think the 1As, we are going to have to move to the 1As because that's our goal. We're finding more of them because of everything that's being talked about at this meeting. But there, I agree with Phil. We're going to have to use MRD and look at ctDNA and follow them. Of course, maybe even await survival data. But we should aspire to 1A. Even a few patients recurring is too many.
Thank you, Roy. Thank you. Another issue that has kind of lurked in between these comments here and in the previous panel as well is this issue of neoadjuvant versus adjuvant. And Raj gave a very nice summary of issues. But one of the things that we have from the thoracic surgeons is a real concern, despite what others have said, about potential delays associated with neoadjuvant type of trials. And so the question would be, are these studies going to accrue? Last but not least, Natasha, you've been waiting here patiently. What are your thoughts about what kind of trial, adjuvant, neoadjuvant, and then again, in regard to what we've already been talking about with the 3 previous panelists, any additional comments? Thank you, Natasha.
Thanks so much. I'm delighted to be here with everyone. I think that, when you weigh up adjuvant versus neoadjuvant, I think we're learning that it will no longer be as simple as the NATCH trial. And I think, where we compare sort of a similar number of cycles of chemotherapy pre and post-operatively, it's going to be a little different for targeted therapy and checkpoint inhibition and other types of immune manipulations, because we really don't know how long people need these to really enhance that cure rate. What I love about preoperative or neoadjuvant studies is you really get that in vivo test of whether or not it helps, as opposed to just giving it blindly postoperatively And the only way you and your patient know that this is a benefit is whether or not the tumor comes back within the next 5 years. So I still remain, very keen for at least some element of a preoperative or neoadjuvant approach. And as Dr. Velaswamy, highlighted incredibly well in his great talk, there are a number of peri-adjuvant trials that are coming out, especially with checkpoint inhibitors, where we recognize that, it's great to get that preoperative sort of in vivo assessment, but then there is this postoperative component that patients, likely probably need if they're going to be cured. I agree with all the comments about stage 1A and what a challenge it is. From my perspective, as someone who mostly deals with advanced disease, I think these are the patients where we probably have the most time to look at preoperative or neoadjuvant approaches. And where we're most concerned about adjuvant approaches, given the potential risk for harm. So that's probably a group where we really could enhance, our preoperative exploration without a significant risk, or in most patients, 90% of early metastatic disease. Harder, of course, in someone with stage 3A disease, but then at the same time, so many of these patients go on to need postoperative therapy that, I think many surgeons increasingly are more enthusiastic about perioperative or preoperative therapy. So I still like that neoadjuvant approach. For immune therapy, maybe it's critical. Maybe you do need to really promote that specific T-cell response to as many tumor neoantigens as you can generate. So maybe it is important. I don't know if we're going to be able to prove it with our current generation of trials. The other thing that, I think it remains of interest, we have these great target therapies. We have great checkpoint inhibitors and other immune therapies that we can move up and really, shift the needle in terms of the toxicity of chemotherapy. But, these patients are probably as much at risk of second primaries and that sort of effect of field cancerization. So I think agents with some preventive effects or other anti-proliferative effects may also be of importance, bringing those forward, because these patients, as we saw in the TRACERx study, they're as likely to get recurrence as they are to get second primaries. And so, we need to be able to tackle both approaches in that 1A group.
Thank you, Natasha. Important points. So we heard Dr. Hirsch suggests that, if we get on with it, we get some of these trials, we'll get a lot more information and we can make better judgments, which I actually very much agree with. But executing trials, especially in 1A, is not going to be a click of the fingers. There's a lot of complexity in getting these people. And, there's other early stage patients that others would include besides screen detected, and that's fine. But it's still a logistical challenge. And so, Fred, when you were at this workshop a couple of years ago, you gave a very nice presentation of the basket trials that were going on in more advanced disease. Is this a setting in 1A where we could justify setting up a structured basket type of consortial approach in order to get these 1A answers in our lifetimes? I'll open it up to whoever wants to jump in.
I'll jump in.
I would like to make a comment. I think Phil Dennis made a very important point, and that is a focus on selection of patients. And of course, we need to put a lot of effort into developing a better selection paradigm. I put in the chat box, 10 different institutions are working in a SPECS grant. The SPECS is an NIH grant, where we validated published signatures for prognosis, and that was published in the last number of JTO. And we haven't done a good job in validation of prognostic signature, but I think selection of patients are important. Is it a role for a master trial in stage 1A? Is that your question?
Yes, right.
That's a good. I think that is a difficult question to respond to on the spot, because again, stage 1A, we need to select, and how do we select? So I would rather put a lot of emphasis into find a good selection paradigm before I jump into master protocols for 1A. But the concept is interesting and should be discussed. I don't have a clear answer to it on the spot. I don't know what Roy and others are saying.
Yeah, well, I would say, given how long these things take to set up, we should start yesterday.
Yeah.
You know, this is the perfect setting, in my opinion, for a basket or a master protocol. You know, we're going to have to find these patients. And now, you know, we're going to start doing next-gen sequencing at the time of surgery. I spoke at the Surgical Society meeting a few weekends ago, and the surgeons were very into this. And, you know, as long as it gets reimbursed, we'll have not only EGFR, as we saw in ADORA, but now we'll have 6 or 7 other actionable mutations. And if we are going to treat the 1As who shouldn't get chemotherapy, but can get these targeted therapies, I think that would be a wonderful setting to do some sort of basket and have multiple drugs available. Again, all the issues that I mentioned earlier regarding toxicity and feasibility. The other thing, of course, to think about is the immunotherapy, as you mentioned earlier, Fred. I'm quite optimistic immunotherapy is going to work for the many patients who don't have the actionable mutations. Just look at the Pacific data. It already tells us actionable therapy works. So I think that could even be part of a master protocol.
Yeah, I'm open for that option too. Don't make me wrong, Roy. And if a consortium can come together in one or the other way, I'm signing up.
Yeah. Right, it's going to take a while for the answer. But now the question is going to be
unless you find intermediate response criteria.
Right, and that's where maybe we have to select with MRD and the intermediate criteria. But ultimately, probably, you know, 1A, I would think survival will have to be, you know, a co-endpoint at least.
Yeah.
Phil, I think this is Phil. I think, you know, one of the things in industry when you do global studies is, you know, so just as an example, in our stage 2-3 study for MRD positive patients after surgery, our screen fail rate due to MRD negative patients alone is 88%. So, and it's going to be even higher in stage 1A patients. So part of this is, you know, it's the operational aspect of finding the patients. I would argue trying to integrate a clinical trials component, an interventional clinical trials component, a basket study, whatever, with the screening process, right? So patients, they're on a continuum, they're on a spectrum. So they get a screen detected stage 1A, they're immediately, you know, no offense to Harvey and the surgeons, you know, before they see the surgeon, they're actually told about possible studies that they'd be eligible for, either as a neoadjuvant or adjuvant approach. So I think there's major operational challenges as well that we can't overlook.
Yes, yeah, no understating that. Natasha, any thoughts?
Not really. I mean, I agree with all the other panelists. I think it's a great time to look into basket trials. Again, endpoints are such a challenge, right? Because even if you have CR, just as we see in advanced disease, does that translate to cure? So I agree with Roy's comments, absolutely. I think that, you know, we also currently, just as part of enhanced care, we do routine NGS on all samples. You know, for us, some of the samples are the size of that initial diagnostic sample, not so much for NGS, but more if you want to do trials looking at immunotherapy, getting enough sample, you know, at what point do those core biopsies actually kind of replace the surgery and removing all the tumor? And so, you know, if you look at sort of the research aspects of sort of the pre-sample compared to the post-sample and what are the mechanisms of resistance and so forth, it does become a little more challenging in terms of the logistics. But I think that a basket trial is great. With 1A patients, you have time to wait the 3 weeks to start them on therapy. I guess, though, it's a bit of a culture change because a lot of patients, once they're told they had cancer, they want that surgery, no matter how big the tumor is, they want it now. So, you know, I think we'll need to work really closely with our surgical colleagues to make sure that people know it's safe to wait to get the results and get put into the right basket.
Okay, well, quick final question. Matthias and David Yankelevitz both talked about doubling time as being a very, very strong marker of aggressive behavior. It's a analysis that could be done. If you can do a CT scan, post-processing can allow you to get a doubling time with or without AI that Matthias mentioned. That's very interesting. But, you know, in terms of feasibility to just get up and running, doing all the other analyses in parallel, but would you think people would accrue to a trial where the determinant of who were the wolves in sheep clothing was decided by a doubling time analysis of serial CT scans that has the benefit of being very, very inexpensive and potentially very available. And then all the other stuff, at least in this first kind of demonstration phase of a basket, you're just trying to do feasibility and work through all these issues that you've all cited, and you keep the trial design extraordinarily simple. How does that appeal?
So Jim, if I have just a moment, I'll just want to say a couple of things about that. First, I'll remind you that this is an IELCART session, and IELCART is a consortium that has been completely interested in doing this, and we've been accruing now. We're starting to accrue at a rate of 1,000 stage 1 lung cancers per year in the consortium, with a view towards getting these kind of trials set up, because all our sites are high volume screening sites. So we're looking for more partners, and we're really looking to do this kind of trial. We think this is the future. In regard to the issue of tumor volume doubling times, as Matthias said, I think this is a very valuable marker. And I think that, you know, in general, we can do this fairly easily. We have to align the protocols to make sure that, you know, because in general, people get 2 CT scans prior to their getting the surgery. So you can, you know, there's when the nodule is found, and then there's usually some kind of follow-up, 3 months, 6 months, whatever it is, where you can see whether or not it's growing before something is done. So frequently you can get that. The other thing I'll tell you, and just as an aside, for those that are bigger than 1 centimeter at least, in ELCART, we are already finding, and it was to a great surprise to me, that the PET scan value has been probably the best predictor so far. We're finding those tumors with the high PET values actually have the highest rates of recurrence. So we're looking at that much more carefully now. We're also starting to look at the whole large data set for volume doubling times to see how much of a predictor that is. So we're completely in line with that kind of approach.
Yes, you had me until you mentioned PET, and I think PET's great, obviously, but keeping it as simple as possible will broaden the potential participation. Comments from the panelists about what Dr. Yankelevitz just said? Roy,
No,
Phil?
I'm very, very supportive. I think, you know, certainly a simple, you know, predictive marker to decide who goes on trial is best. I would agree with you, Jim, though, from the Adora experience, you can't expect PET if you're going to do a large, you know, international trial. CT would have to be done.
Yeah.
Tim, I would like to make a final comment. I need to run in a minute here, but
yes.
You know, in advanced disease, there are currently thousands of all kind of clinical trials. We need to move the enthusiasm, and we need to move the effort into early stage disease, and really start focusing on multidisciplinary trials, not just medical oncology, not just surgery. You mentioned radiology, metabolomics. We need to move the whole enthusiasm in this direction, and move quickly. We are way behind in lung cancer. With that, okay. I need to run and apologize.
Fred, please run. It's good exercise. And you know that I'm not going to argue with you about your concluding comments, but I would like to say the last word for Natasha, because she waited for her initial comments. Natasha, final conclusion from this really wonderful session. Very promising. Your thoughts?
So I agree, whatever we can do to enhance that group at the highest risk we need to do, whether it's, a combination of liquid biopsy, PET to identify. And then I think we, as Roy said, we really need to enhance our molecular understanding of what makes these people high risk. And that also, I think, reflects Harvey's and earlier comments. And it's more than just the tumor, it's also the host. But I think this is where the future is in lung cancer for sure.
Well, thank you, Natasha. Thank all our panelists for an excellent discussion. Raj, excellent summary that set us on the right steps. And we'll look forward to additional comments. And thank you all and have a great day. What happens now with the overall workshop is it's time to move into the break. We have a 15-minute break, which we're surprisingly on time for. And what will happen then is we'll separate into two breakout groups. The group looking at the issues related to integrated imaging of lung cancer with COPD will stay in this room. And then there's instructions provided with a link. Yeah, son of a gun. Yes, we are. So both groups will actually be in this room because we're going to hear from the readout of the deliberations yesterday from the CT group that was thinking about integration with COPD characterization in the course of lung cancer screening. And then after that, we'll go into the deliberations from the molecular therapeutics breakout group that occurred yesterday. So we'll be back here. You can just stay Zooming for the next 15 minutes and go catch a cup of coffee and do whatever else seems appropriate. Thank you all. Appreciate great session.